From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to our listeners around the world. This is the JAMA Surgery Podcast. I am your host, Dr. Amalia Cochran. Our topic today is the prevalence of use of biologic and biosynthetic mesh for ventral hernia repair. And today I'm getting to speak with Dr. Ryan Howard.
Hi, great to be here.
And Dr. Dana Telem.
Hi, thanks for having us.
Coming to us from the University of Michigan Department of Surgery. Well, we are going to talk today in most detail about your recent cohort study examining utilization patterns of both biologic and biosynthetic mesh for management of ventral hernias. This work is one of two recent studies your group has published in JAMA Surgery. Can you share with our listeners the origin for the idea to generate both of these works, looking at component separation and biological and biosynthetic meshes?
So both of these papers address different gaps in the current knowledge about ventral hernia repair. So that first paper you mentioned about biologic mesh use is a study that's trying to address the here and now. We have this registry that is very granular and very detailed about what types of mesh are being used, how are these hernias being fixed. And one of the questions we wanted to answer is, in practice, what's actually happening out there when surgeons have dozens of different types of mesh to choose from and all these different ways to fix a hernia, what is actually happening? That mesh study is attempting to really paint a picture of what's going on in current practice. The component separation study really leveraged the strength of Medicare data. So while in Medicare, we don't really have granularity, right? We don't know what kind of mesh is being used. And often we don't even know what size the hernia was. We do have incredible long-term follow-up. These are patients who are on Medicare for years or decades. And so another kind of black box that we wanted to look into was in the 5, 7, even 10 years after the hernia repair is done, what is happening to patients? And in that case, given how much we've seen the use of component separation increase, did this have an effect or play a role in the really long-term and late outcomes that patients are having after hernia repair? And it turns out that we did see an effect of using component separation all the way out to a decade after surgery.
I think these two works are pretty representative of our group as a whole and where our passion is. We want to help fix hernia disease for persons in this country. We joke a lot that there's a lot of attention spent on many different topics, but not as much attention sometimes spent on the topics that really impact all of our patients, whether it's gallbladder disease or hernia disease. Every single person, no doubt listening to this podcast, has an uncle, a brother, a mother, a sister, or somebody who has that. And we've really dedicated our focus, not just in the state of Michigan, but across, on quality improvement, because it's kind of exciting. It's still like the Wild West. There's a lot more anecdote that there is evidence, and we hope that these two papers start chipping away at the data we need to make better care decisions for our patients, not just in the short term, but in the long term.
I was curious to hear a little bit more from you all because you are clearly the content experts on this particular database that you used, the Michigan Surgical Quality Collective Core Optimization Hernia Registry, or the MDQC-COHR. What are the benefits and the limitations both of using this particular data set?
This has been our passion project for a really long time, and we started the registry back in 2020. So for those who don't know, Michigan is a really unique state where we're almost a single payer state. And many, many years ago, there was a decision to do statewide quality collaboratives and improvements through sharing amongst different hospitals. And in 2020, we were able to leverage that to start the hernia registry, which is essentially a collaborative of anywhere from 69 to 72 hospitals, depending on the year, who share their data freely. When we first started, we really were only able to collect 30-day data, which is a key limitation when you think about a quality of life longitudinal study, because you don't measure the outcomes in hernia repair by death and destruction at 30 days. However, a couple of years ago, we were able to add longitudinal follow-up for 1 year after surgery, and through a weighting sample, actually have a really great population level sample at 1 to 2 years after hernia repair with things like decision regret, self-perceived recurrence rates, hernia quality of life, and a whole bunch of other patient-reported outcome metrics, which I think will be the key for us to be able to start making better recommendations. It's a labor of love and it's a lot of work, but we wanted to emulate as best we could what we were seeing sort of in the European registries, where it was really about population level data with population level follow-up.
In reviewing the findings from the current study, looking at the biological and biosynthetic meshes specifically, I was really puzzled by the finding that a diagnosis of obstructive sleep apnea was associated with decreased use of biological or biosynthetic mesh for these patients. Do you all have any hypotheses on why this was true? Because I just couldn't make sense out of that.
Yeah, that's a great question, and it kind of caught us off guard as well. I think on the one hand, that certainly just speaks more to the methodology. When we do these observational studies, we try as best we can to control for all the different confounders and all the things that have effects, because obviously there's going to be a million different influences on whether or not someone decides to use biologic or synthetic mesh or what the patient selection criteria are. So that leads us somewhat to think that is something that just probably doesn't really have an impact and just didn't quite shake out in our ability to control for all the different confounders. And I think it's an important lesson too, in that you try to control for everything, but even before you throw all these variables in, and that is a benefit of this registry, is it's so granular, you really have an idea going into it which variables you're most interested in. So we went into this really wanting to see, well, is surgical site contamination associated with it? And it was, but there was still a lot of biologic mesh use in clean repairs. Was emergent surgery associated with it? Yeah, it was. But there was still a lot of biologic mesh use in elective repairs. So I think you caught on something that kind of caught us off guard too, and is just out there for people to make of it what they will.
You all did a really nice job effectively presenting the three most substantial findings from your analysis, which I summarize very briefly as the infrequency of biological or biosynthetic mesh use, the frequent use of biological or biosynthetic mesh in clean elective ventral hernia repairs, as you just mentioned, and then the incredible skewing of the use of biological and biosynthetic meshes towards certain hospitals and surgeons. I would love to know which of these findings was the most intriguing to you and why.
The first finding that it's used in about 1 of every 10 cases, I think that kind of tracks with what we expected. It's infrequently used, and that was reflected in the data. The second finding, that 90% of its use is in clean repairs and elective cases, I think that was really surprising to us, that this mesh that ostensibly was invented in the first place to address the issue of can we get something that's safe to put in a contaminated field is being applied in all these clean cases. But to really answer your question, I think the truly most intriguing finding was this skew. And that is really one of the more powerful quality improvement levers that we have when we use this registry and when we do this work in Michigan, that we can kind of break it out across hospitals and surgeons. And just to kind of put a finer point on that, we found that it was about 7 hospitals out of a total of 70 that accounted for half of all the biologic mesh use, and it was 23 surgeons out of 500 that accounted for half of all the biologic mesh use. And I think that's a powerful thing, because when we as practitioners can see where we stand in relation to our peers, it's very informative. And I think those are the kinds of findings that can even inform and drive practice change. We saw this happen with post-op opioid prescribing, where when we fed this data back to surgeons and a surgeon saw, hey, I'm in the 99th percentile for my size of prescription, everything kind of started to change. When you think of what you're doing, you usually don't want to be an outlier in what you're doing. We're excited about these data and these skew because it really does tell us there's probably a chance to get people on board to change practice for the better.
And one of the things we've noticed when we've gone around and talked to different practices around the state of Michigan is this dependence on opinion leaders, dependence on group practice that really outweighs and trumps evidence sometimes. And that's normal, right? You're going to do what your colleagues do. You're going to do what's on the shelf. That's not unique to surgery and it's not unique to hernia. But in the areas where we have been able to see this skew and sort of this heterogeneity or these differences in practice, whether it's in preoperative optimization, opioid use of synthetic mesh versus biologic mesh in clean contaminated cases, use of component separations, we've seen some skew for use in 2 centimeters. It gives us an ability to understand what, number one, is there a problem, right? Because means and medians kind of lie on the extremes. Where is the issue and how can we work together? And I think one of the really cool things that are coming out of this work, so when we get data like these, is we've actually put together a core, we call them. So it's about 15 surgeons from heterogeneous practice patterns from around the state, private-demic, up in the Upper Peninsula, as private as you can get. And we've all kind of had our first hernia summit here back in September. And we've created avenues, and we're going to start these quarterly meetings where we're going to feed back this data and not tell people what to do with it, but just say, hey, what do you think about this? And how do you want to go about this? And sort of leveraging all of our partnerships to create change instead of us trying to push it through.
So as I read this article, I was quickly drawn to thinking about the role of implementation science in clinical care. And the fact that so much of the use of biological and biosynthetic mesh is honestly not based in current evidence. How do we help to accelerate practice change regarding the use of biologic and biosynthetic mesh for ventral hernia repair? And for that matter, who should be getting meshes with component separation as well, going back to your other study, with our colleagues and within our institutions?
I think it comes down to really two questions. One, how much evidence is there? And is it an issue that we don't have enough evidence? Because if that's the issue, then we need to generate the evidence in the context of its implementation. Or two, do we know what the evidence is? No one's going to sort of fight back that it's the right thing to do for most clean cases to put in a $30,000 piece of mesh. But why aren't people doing it? And that's where our hard work starts. And that's where things such as coming up with our core, talking to people, understanding why people are doing what they're doing, and then designing interventions that are aligned with the barriers that we're finding rather than us pulling them out of the hat. And we actually have a couple, one ongoing and one about to start, fancy term type 3 hybrid effectiveness models. We're basically just saying we've tried to identify different interventions. We all know that interventions to change practice are costly. Not everybody needs everything. So how do we decide who needs what? And not only who needs it, but when do they need it? And so no doubt we'll go and we'll interview and we'll find out about mesh. We'll find out one person, this is the only mesh they stock. They're going to need a different intervention than another person who says, I'm just going to use it and I'm just going to use it. Maybe nothing we can do there. Or somebody who says, I'm worried about, and they might need an educational intervention. And that's the fun part. That's what we love to do, which is the practice change. It's not just the generation of the evidence, but how do we deploy this to change practice? And I think we've done that so far with preoperative optimization. We've made some movement, a little bit of movement in the state, but still have a lot of work to go, but phenomenal partners to do it with.
Dr. Telem's so right. That is 100% the most fun part of all this. And I view this study as kind of the first step in really starting that work, which I think is the crucial and important work, right? You could imagine if we just came out and said, hey, here's a new initiative where we're going to get everyone on board with the right type of mesh. You could look at our data and you could say, well, there's 300 surgeons that don't even use biologic mesh. And so, like Dr. Telem said, actually identifying which intervention is going to be most beneficial for which site or which surgeon can be very powerful. And the last thing I'll say about that is even before some intervention or some quality improvement project, again, just simply getting these data out there to the surgeons themselves so that we all know, hey, where do we stand in the continuum of mesh use or the way we repair a hernia? I think that's so powerful. And I think it makes the community of surgeons partners in all this work, because then they have a voice and they say, well, I am a low outlier, but here's why. Or I am a high outlier, but here's why. And it may have to do with what's stocked at the hospital, or it may have to do with some concern they have about the evidence. But I think if you're really going to change practice, you need that partnership of everybody, and publishing data like this, I think, is really kind of a crucial first step to creating that partnership.
Dr. Howard and Dr. Telem, thank you both so much for your time today. I really appreciate learning with you.
Thank you so much, and thanks for highlighting this work and helping people with hernia disease.
Yeah, thank you so much.
I am Amalia Cochran, the Web and Social Media Editor for JAMA Surgery, and I've been speaking today with Dr. Ryan Howard and Dr. Dana Telem from the University of Michigan about prevalence of the use of biological and biosynthetic mesh for ventral hernia repair. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved. including those for text and data mining, AI training, and similar technologies.